Hello, I'm Dr. Jane Cooper and this is Assessment Task 2A for CAM 509. My pitch is an on-campus clinic for young people, the constraints to providing accessible and affordable healthcare with this model of care. In 2013, I established an on-campus bulk billing clinic at Don College, which is an educational institution for grade 11 and 12 year students who are 16 to 18 year olds. It complemented a whole school focus that incorporated other services to support the young person. The constraints, though, were financial, being only bulk billing, there was risk being a lone clinician in this setting, and there was lack of care outside of school hours. From here, we established a mainstream accredited general practice in the CBD. This has provided care for people across the spectrum of ages, and therefore we also had full fee paying patients, access to Medicare incentive payments, bulk purchase of consumables, an established admin team, and the clinic was youth friendly, so it complemented the on-campus clinic, which became a branch practice of the main clinic. In the context of the theory of constraints, the clinic, though, is unable to continue in its current mode into the future for not being financially viable. The constraints are around cost, the Medicare rebate being set and very limited increase in that over the last few years, and the lack of item numbers that are youth specific. There's lack of manpower on the northwest coast of Tasmania where this is occurring, with limited clinicians with an interest in a skill set in adolescent health. There are staff costs, consumables, and rent, and if the doctor is allocated to the on-campus clinic as opposed to the mainstream clinic, there is a loss of up to $20,000 a year to the main clinic, which has a huge impact on running costs for the small clinic. Why is this on-campus clinic important? Because adolescence is associated with significant issues relating to mental, general and sexual health, LGBTI issues, cultural and linguistic diverse issues, and a number of social determinants that can impact on a young person's well-being. The Lancet Commission into Health and Wellbeing for Young People in 2016 demonstrated that the antenatal and early childhood areas are very well funded and we get very good outcomes. Chronic disease and aged care, also very well funded programs and very good outcomes, keeping people out of hospital. But there has been very little addressing of this area, looking at ensuring young people approach adulthood in their best mental and physical health. Young people themselves tell us that the GP is their first go-to person, that they want to be asked tricky questions and they won't bring them up, but they'll often also not present when there is a problem. They tend to present in crisis. Accessibility and affordability is important, and access to GPs who are youth-friendly is also important. From a GP perspective, though, dealing with young people has significant medico-legal implications. It's a very grey area. Young people often don't talk, they don't turn up, they take too long and they have no money. And there are very few item numbers that enhance GP engagement with young people. There's a lack of understanding of the problems facing young people, and if they do identify them, what to do next. The on-campus clinic is an excellent point of contact for the services and the young person. If we consider this model of care where the young person is at the centre, so keeping in context that patient-centred care, we want to follow this pathway, reduce risk, increase protective factors and get school engagement and employment. At the moment, most of this care is being funded at this level. The school, of course, is providing a room, but that is at low rent, but they also provide a whole lot of other collaborative services. The government, I think that this area could be further reviewed to look at what other services could be supporting this service here. So the project in the context of theory of constraints is to identify the constraint which I've outlined, decide how we can exploit this by mapping the patient journey, reviewing current processes, looking at costs and the number of patients. Subordinating everything else. So reviewing clinician tools. Are there ways these can be reduced in a lean way to save time and cost? Elevating the constraints. So can we get support from elsewhere? Can we use a school nurse program or the youth health nurse? And at the end of the day, should we be reviewing policy? Who is actually responsible for this program? Always returning to step one though, because if there's any inertia, there is a huge risk of losing money. At the end of this journey, the short-term goal is to establish a policy statement for state health and education departments to consider funding for a pilot of an on-campus redesign at Don College in 2019. If it proves successful then in addressing the constraints, to then ultimately be rolled out across both high school and college levels in the state, and thereby improving young people's health in our state. The long-term goal, of course, would be to canvass the federal government to review the Medicare rebate and argue for the establishment of adolescent-friendly Medicare item numbers. This, of course, will be another project. Thank you.